welcome everybody we're going to talk about the mental health pathways, which is a collaboration between Police Scotland and NHS 24 and our ambulance service here in Scotland. And it's about the first point of contact. I'll introduce myself. I'm Claire Coleman. I'm a police officer with Police Scotland, have been for 18 years. It's coming up for next month, and I've worked in various areas from public protection for a good majority of it, and now working in a job which actually I really enjoy, which is about the Mental Health Pathways project, but working in the training, engagement and the valuation side. And I was meant to be joined by colleagues from Police Scotland and NHS 24. Unfortunately, everybody's job has pulled them all away today, and I've got the beautiful Inga instead. So I'll let you introduce, in case anybody doesn't know you, Inga. However, I think
there's lots don't know me. Thank you, Claire, and it's an absolute pleasure to jump into this session with Claire, because, you know, if we could bottle half the passion that Claire has for all her work that she does, we would be set in Scotland. She's really driven forward so much of this work that in her passion for everything that she does is amazing. So I'm so, you know, delighted and honoured to be standing here today supporting Claire when other people were unable to come. So my name is Inga Heyman. I am a mental health nurse, and I also work in academia. So my PhD was on mental health pathways with police. So I work quite closely with Police Scotland in lots of different forms. I'm also co-director of the Scottish Centre for Law Enforcement and Public Health, and had the absolute joy and pleasure of hosting LEF 19 when it was in Edinburgh 2 years ago. So that was our pleasure. So I'm very pleased to be here. I'm just going to be asking questions more than anything else and kind of keeping an eye on the chat. So
perfect. Thank you, Inga. I've got a couple of slides to share with people just to open it up and explain what the mental health pathway is here in Scotland. And I'll just load that up just now.
Just as you're doing that, it might be interesting just to get delegates to pop in the chat box what country you're from, just so that we can have a feel about where people are from. So if you don't mind, just tapping in to the chat box what country you're from. And we'll come back to that in a little minute. Thank you.
Yeah, thanks, Inga. You know, it's really good to hear where everybody's coming from, because there's so much great work out there and it's everybody's passion. So for us, we've got a little strapline from the mental health pathway, and it's about the right care, right time. And it really is. We're looking at the first point of contact. So the minute for when it comes into the police, that we effectively assess that and actually look for the best journey for that person. Not really once we've deployed officers, because at that stage we've maybe taken that person on the wrong journey. So, you know, I'll flick through. So, apologies, that's our timeline. So we started back in 2017. It was funded by the Scottish Government, and they said there needs to be better collaboration work between Police Scotland, NHS 24 and ambulance services in Scotland, and looking for that mental health crisis response. So collectively we came together and we started meeting fortnightly to really get to better understand where we all come from and what we thought our ideas would be best. Knowing the geography in Scotland, you know, it's quite a popular thing is to have a trauma car, but the geography in Scotland just as such wouldn't really be able to fit the remit for everybody, because it's so vast and rural in some parts, and then we've got that central belt area. So we needed something national. So that's why we turned to the NHS 24 approach and looked at the telephony for really getting that first point of contact.
Claire, can I interrupt? Can you maybe explain to the delegates from states or from other countries what NHS 24 is?
Yeah, certainly. So
sorry.
NHS, no, definitely. So NHS 24 is our national telephony service for medical. So instead of turning up, particularly handy for COVID, so instead of turning up to an A&E department, it's, you know, it's unscheduled care, where if you need to speak to a medical practitioner 24/7 and get medical support, unless it's an immediate trauma, as in, you know, it's life or death circumstances, you phone, it's 111, which is a free call number, and you you're looked after medically. So if it's something like being prescribed antibiotics, if you're needing to get a scan because you've potentially broken your leg or something like that, then they will deal with that kind of, that mid-level kind of crisis all the way through, and then they will direct you to the most appropriate care. In regards to so it's works for the whole of Scotland in respect to that, and it's really supportive. So that's NHS 24.
Thank you.
So yeah, so we work as I say, NHS 24. So and SAS, which is our ambulance. So that's your vehicles going out and about to give remote care and support to people who are in need for immediate response. So we work collectively together, and we looked at really breaking down the barriers and understanding where we all come from in the collaboration between ourselves and organisations. And then we moved through so at that point we realised that the best way to effectively to support this nationally is to really upskill our own staff in Police Scotland at the first point of contact, and then but then bring it together where we would at the point of the phone call really coming into Police Scotland to assess it effectively, and then refer that person straight into NHS 24 on an immediate, it's a priority line where they get to speak to a psychological wellbeing practitioner, which is a very new role. So that isn't somebody with a clinician's background. They'll have had maybe really good community work. They are great communicators. One of them is previously was a police officer with 18 years service, people who have been out there and spoken to people in the community and worked with them in that respect, and then we can just put that person across into there, and they will be speaking to them within 3 minutes of us making that referral across. So it's immediate care for that person and support around their mental health crisis. So as you can see from the timeline there, we've done massive amounts of collaboration work with each other, as well as done testing and live scenario exercises, and then we launched in August this year. And we're just on our 6 monthly, so we're at the stage now just for evaluation. So it's been quite exciting for us. So as you can see there from that diagram, the public can come in, they've got a direct line in, but Police Scotland have got it in. That's our key criteria there. So any public contact by a person who's 16 years or older, where there's no threat to life to them or any other person, they're not going to immediately harm anybody. They're not going to look to, they're not in the stages of completing suicide. We've done a lot of work with our first point of contact in respect to that and worked with them. And then we move around that as well. And there's no other big reason why the police need to go out to that. We split calls is the best way to describe it. So if somebody's got a minimal reason for the getting in touch with the police, what we is kind of like your minor reasons, their shed's been broken into, something like that. We can split the calls, they're distressed, we can go out and see the person tomorrow, but we can get them immediate mental health support for them straight away. And then within the hub, they've got various options. So they've got, as I say, the psychological wellbeing practitioner is greatly supported by both mental health nurse practitioners, and seniors are there floor walking and working with them in tandem. They can put referrals across to their general practitioners, doctors out in their community. They can speak to their community practitioners, mental health nurses as well, if they're getting support and such. So there's lots of ways we can look at DBI, so distress brief intervention, and their breathing space, lots of options once they've gone into the hub. And for us, that person can be referred as many times as we need to refer them into it. So we've got some people who've been referred through Police Scotland. Now we're sitting well into the double figures, but they prefer to get in touch with us. We've tried to get them to go down the 111 directly, but for some reason they still prefer to go through us, and we'll still refer them in. But it's just the feedback so far has been pretty phenomenal for it. Our main reasons for contacting us have been identified, people stating that they're suicidal, and that, but we do a lot of questions around that. So we've worked with Inga and Napier, as well as ambulance and NHS 24, to make sure our training's right, that we're asking these key questions when people either state this or they're by the way of their actioning over the phone, that we're concerned about them in respects to that. Their low mood, anxiety, all the things you can imagine. What people phone us. We have a lot of lonely people phone the police because we're there 24/7 and we'll speak to them. And then they have we have around COVID, we have a lot of people also getting in touch with us because it's problems with neighbours, and that's simply because they're at home all the time, I can see, and their neighbours are driving them pretty crazy. A lot of noise complaints about neighbours, and they're needing that additional talking therapy and support, maybe a bit of mindfulness, you know, very, very much all that kind of stuff they can do remotely over the phone. So as I mentioned, we've come to our 6 months period. We've done our 6 months evaluation into it. At that point, between August and the end of February this year, we'd referred 777 referrals, but now we're sitting well over the 1,000 because we've got more people have been changed since Christmas time, so the numbers have dramatically increased. We're sitting with a 97 success pass rate from Police Scotland direct into the hub, because there is times when we cannot get through to the hub, even with our priority line, even that we've got a ring-fenced psychological practitioner waiting to speak to them. We just can't get through because the demand is so great even from Police Scotland and externally with the wider public. And there's constantly massive recruitments going on to really bolster the hub. We've got 3 initiatives have been identified, and in that we've noticed it was also a lot of people are getting back in touch with us, and we call it, it's because we've had dealings with them. They've been arrested by the police, they've maybe spent a night in the cells, they've been released a couple of weeks later, or it's coming to the court date, and they're upset and they're concerned, and they get back in touch with us because they don't know what to do and who to reach out for. And so what we're doing is, part of their release documents from the police, we're signposting the hub and other services, which are some really great local services across Scotland that will be specific to that person in the area that they live in, but they'll have the national response, the mental health hub as well. We're looking at bringing nurses in, and that'll take effect in the summer this year. So we've got additional funding. So nurses, mental health nurses, will be based 24/7 within our control rooms, which is quite a common practice now internationally, certainly from the research. So they're going to be there, but they're going to be there to take not the referrals, not that level. They'll be there for a more more urgent care, maybe when officers have been deployed, when somebody is in the stages of looking to complete suicide, if they're standing at a bridge or something like that. That's where they're going to be really supportive around that. And really for us, what we found from the evaluation is that 93% of our police referrals, it ends in a non-emergency endpoint, and that can be literally they've made a referral across, they've made the GP aware, and the GP is going to make contact in their notes, whether it's been self-care and such. So for us, that is phenomenal, because for us in Police Scotland, when we deploy to an incident, on average, it's 7.5 hours for every police officer who's deployed to a mental health incident. But that's great for a start if you're looking at it, but really it's been the wrong journey for the member of the public. They've ended up going to the hospital, being present with the police officers, and had to go through what would be actually not a nice journey at all, being standing in an A&E department with 2 police officers instead. But for the police officers and everybody, from our people who answer the phones all the way through, they know this person's going on a better journey. They had no other route to send them apart from sending 2 police officers. And the person simply needed some mindfulness. They needed to talk through their problems with somebody who was there to support them. So that's where we're sitting now, 6 months in. Interesting, so far so good, touch wood. And as I say, the nurses are coming in. So that's kind of where we are with the pathway.
I think it's really interesting, that idea that, it's such a simple process about diverting that call to the right person, instead of deploying and you were saying it would be a police officer for about 7 hours. It's actually 2, isn't it? It's 2 police usually doubled up always.
So they say for one police, but it's 2 police officers in Scotland. So you're looking at 15 hours on average. Deploy the police officers. So from the minute the call comes in, they get dispatched, they pick the person up, they take them to hospital. Now, what's interesting about our pathway is we can refer people who've consumed alcohol or drugs, but they're not intoxicated. They're coherent. We can have a conversation with them. They understand they've got to consent to the referral. We can't force people into referral, but as long as we can have a conversation, then that's fine. Which certainly from my experience as a police officer, is if I present with somebody to a hospital, A&E or a mental health hospital, they will be breathalyzed, and if they have taken any form of alcohols or they're intoxicated, they will not assess them. But the mental health pathways will, because they are quite happy to say, this is sometimes the only way this person will present, and you may never get them in any other state. But as long as we can have a lucid two-way conversation, then we're happy to refer them across.
And so I think there's something really interesting there about, stopping that, the point to deploying police officers, because it's not, like you said, it's not just about the time, it's about the dignity and the experience of that person, because police officers being police officers are quite risk averse, and will, when it comes to mental health, actually don't feel like they've got a lot of discretion around the decision making they'll make, around that. And so we'll stick to policy quite strongly. And so that person will be headed down a route towards the emergency department or whatever, whether they like that or not. Yeah, whether they want it or not. And I know that police officers use a lot of your soft skills to persuade people to be, because police officers need to have somebody assessed. It's unfair. What you're doing is stopping that whole ball rolling in the first place and making it right for the person.
And because we're at this state, we built in that when we do refer somebody, there's a chance they'll come back to us. So we call that an emergency intervention. It's not because it was a bad referral, because this is all good well-being for our own people, but we call it an emergency intervention because their conversation, somebody who's more qualified than a police officer has had that, and they've got their notes, so they've got the access to the NHS 24 notes on that person. And they say that person 20 minutes into the conversation discloses, I've taken a quantity of tablets, which they haven't disclosed to anybody else. So it will come back to us, and it'll be a joint deployment by the police and by our ambulance. But what I've seen is, because I have reviewed every referral that's gone across, because we've been very key to make sure we've got everything right, is that there's a maturity now that actually the collaboration works together. The three of us work together to either find that person, support and get that right route for that person to begin with. And when the officers are being deployed or ambulance are being deployed, we're actually in a better position when we do go to get that person, when we have to, step over the door.
Claire, can I just ask you, I'm just looking at what the countries everybody's come from, quite a few people from Canada, US, Netherlands. Hi, Victor. We've got quite a few, people from a range of countries, and it'll be really interesting to know what sort of systems, if this overlaps with some of their processes in what's happening in their own countries. Certainly, I know Amy's work in CIT is really, there is some good similarities here. It'd be interesting to see to tease out any, challenges or whatever. I wonder, Claire, if you could maybe speak a little bit about what, if it was somebody who was wanting to do this type of intervention, what were the challenges for you? Because I know there were a few.
Oh, there was. We could have launched, if we hadn't had the challenges, about a year before easily. Our aged technology in Police Scotland. So Police Scotland previously was 8 forces that were all brought together, and there was a bit of a stick and plaster was put across our telephony. So when we looked to actually transfer the call into NHS 24, we found that we were still recording that call, which is a breach of our GDPR data protection. So we couldn't do that. So we looked at, we've got a different route in. So doing that and all the paperwork and the information sharing takes a significant amount of time. And that was us getting absolutely everybody who's been part of it all the way through, including the UK and the Scottish government, have always been very supportive of it. But just getting it off the table to that stage and making, I would say our ICT our telephony, because it's so old, has hampered us greatly. And then trying to get through through our data sharing process, because we have to, obviously, we're dealing with people's data, we have to be very protective of it.
Mm-hmm. Absolutely, absolutely.
And then when COVID kicked, so I had the initial batch here, about 700, just under 700 people to train, and COVID kicked in. And this was to be really a hearts and minds run with our people, to trust that we're first time ever in Police Scotland that we have ever done this. And in fact, policing in Scotland, even before Police Scotland, where we've been able, we refer and we leave the responsibility, because part of the handover to NHS 24, we state referral complete. And that means that NHS 24 at that point are fully responsible for the journey of the person after that. And it's very much, it's over to you, really. You've got the ball, please run with it now. So when it came to the training, we still wanted to continue that, but all our accommodation was getting used for shielding and COVID supportive, so people who do need to be into police environments were there. So we literally, I converted a wellbeing van to a mobile training unit, and it passed health and safety, I have to say, for anybody who's listening. They said it was fine, and literally trained in the space about 6 weeks, just under 700 people, and put them through. And the mobile van went round and parked up in the car parks and in the different areas, and put them through and cleaned it down and everything. And my training team were an absolute, and we ran from about 5 in the morning till midnight to put everybody to, so we could still meet our launch date, because we know the demand was just going to keep growing because of COVID, and it is going to keep growing, obviously. So things like that, but they're quite funny challenges, taking out a little mobile van and taking everybody through it. And touch wood, there was no COVID cases, there was no outbreaks, because you can imagine that wouldn't have gone down too well for us as well.
I think there's something interesting as well from how, I mean, you just touched on it there, that it's quite difficult for police officers to let go and not lead on something. Just in case, and being quite risk averse. So you did touch on that to say, actually, it was the first time that Police Scotland have really taken a public health approach to policing, rather than being asked by public health to do something. Like, it's really pushed, you've pushed that forward from a policing side, which is quite different to other approaches. And I think, stepping a little bit back from your timeline there, for delegates who might not know what was happening prior to that, they're from the Scottish government. So, from our Scottish government perspective, they pulled together a very senior board of the Health and Justice Collaboration Board, and that was most senior police constable, the most senior in our health services, in ambulance service and fire and rescue, pulled them together onto a board and said, look, we need to really thrash out this collaboration part of things and try and look at what our key priorities were. And one of the 3 key priorities was the mental health pathway, or in developing new mental health pathways. And on top of that, there's been some really strong leadership within Police Scotland, but also, Public Health Scotland as well. But ACC, John Hawkins, who's Claire's big boss, the big boss, is incredibly passionate about this work.
Mm-hmm. Yeah, and our next stage, so we're at, as I say, we're bringing nurses in between. At this stage, I'm just about to launch it nationally, so every relevant police officer and member of support staff, whoever will benefit from the ability to refer in, will be getting this additional training. And again, and that's what you made me think about it more, Inga, is we've got to get our police officers who have either come across the circumstances, or I look back to my own self when I worked in public protection. and I've maybe taken a statement of a victim. I've been there for 4 hours and I'm leaving them in an upset state. And I am, of course, they've discussed something, historical abuse, or I can refer them into the pathway and they can go and get that talking therapy straight away. It's not 6 weeks later. It's not through a doctor. They can phone up and get that support, and I can leave that person. And it's my next stage is really, as I say, we're going to nationally deliver it, is making sure that our police officers out in the street feel the same way as the officers and staff who have currently already, they've given the ball over, and we need to do the same and feel happy about leaving people and walking away, not sitting there for a 40-minute phone call and listen to them with NHS chatting away about their mental health. And it's saying, you know, it's time for, they're with the professional now who is the best placed person, and they will get back in touch with us at any point if we've got concerns.
Just pick it up again on something you just said there. It was really interesting, is about non-medicalising distress. So, you know, you gave a really good example there of somebody who didn't have a mental health disorder, but might be really distressed because they've just disclosed something. We don't need to medicalise. So it doesn't need to be a GP, a general practitioner, or a doctor who necessarily deals with that. Somebody in the hub who isn't necessarily, you know, a nurse or anybody else can deal with that process. And so we suddenly have a different pathway out with this sort of binary criminal justice health process, which is really what we need. Yeah.
And I think that's for my, certainly from my experience, that is really one of the key things. But it's not, if I go back and I put my uniform, I'm back out there, or when I was a detective and I was back in somebody's house and I've left them upset, is thinking, well, I could put a piece of paper into a computer system and maybe 3 or 4 days from now it'll go across to maybe social work, or it'll go across to health. But actually the referral system I can get in 10 minutes. So it's within 10 minutes. It's actually on average 3. I'll be, because literally we ring fence them straight away, but we say it's you know, it's 10. Is I can get somebody to speak to you now about how you're feeling, not tomorrow, now. And we can put in some really good, they'll put some really good coping mechanisms in, and they'll put some techniques to help support you. And that's, and your GP will still get made aware, so it's great, you know, so if there's any additional needs.
There's some good questions coming up here that I'll ping to you, if that's okay, Claire.
Yeah, of course.
So there's one here that says, congratulations on your innovative police-led health approaches to mental health distress. I understand you can refer people who have had alcohol if they can have a conversation, but how do you handle people who are intoxicated and can't have a lucid conversation?
Yeah, do you know, it's traditional routes still for that, because there is nothing we can do. We can remotely assess as much as we want. We can have like access to all these systems. However, if we can't actually understand what's going on in that person's life, we could never refer them to anybody else. It would be wrong, and we'll still be deploying to that. There's that. These are all the little grey areas. We're getting our grey areas are getting smaller, but now they're focusing more on, well, what do we do for, is exactly, you know, the severely intoxicated person who phones up. What tends to happen, my experience, because I look at a lot of police incidents very much like this, is by the time we've attended, and I don't mean hours later, I literally mean in a very short period of time we've attended, they've forgotten and they've gone to sleep, and we wake them up and then they can't remember us. They can't remember in any shape or form calling us. And it's just they've been lonely at that point and they wanted to talk to somebody, so they phone the police. That seems to be certainly my experience from a lot of the review work I've completed on that area.
Here's a really nice question as well from Christine. Christine is asking you, it says, Claire, you spoke about training 700 people. Is this the number of people in your police force, or is this the number of people staffing the support programme?
No, that's I've actually trained more than that now, well over probably close to about 2,500 now. So in the police force we've got 15,500 on roughly police officers, and we've got another about 6,000 members of support staff. So I would like it that actually all of us would actually have the awareness. And
6,000 or 600?
6,000 members of support staff.
All right.
So, because as me, I have to say, one of the most nicest things is somebody who's been really in the project and developed the training and everything and delivered it, was when I've had two of my learners have come up, post one to one of my trainers and one to myself, saying, I've actually used it for a family member, and they were absolutely fantastic. And if you can get that 360 out of it, there's nothing best when you know you can actually make that positive effect. So, so far, yeah, we've probably got about 2,500 people trained, and it's literally only for the initial training when we first launched it to give that full awareness, it was an hour and a half, and now it's down to 35 minutes, and it's remote learning with follow-up. We do follow-up team sessions with Spocks embedded into every team, so they can come back.
What's it, what a Spock is?
Oh, sorry, single point of contact, like a champion. So we have champions within every team where, so they go, they do their online delivery of the training, and then the champion within the team will collate some questions and such like, and then we'll just do teams with them, so we can get round the whole of Scotland, because they're all spread out everywhere, all these various teams.
So just for those who don't know anything about Police Scotland, it used to be, as Claire said, it used to be 8 forces, and we collaborated into one force. So we're the second biggest force in the UK after the Metropolitan Police. So it's a big organisation, but it also has benefits because it's one force. Mm-hmm. I think there was quite a lot of resistance originally to it being one force. Huge resistance, and I was working in police, Grampian Police, when it was one of them, and it was huge resistance, but it's actually been incredible, and it's really allowed work like this to go ahead. Just please raise your hand if you want to ask a question live, or pop something in the chat box. There's a comment here from Scotland. And it says, this is more a comment than anything else, but a key ingredient to this intervention is the entrepreneurialism, and I can't say that, entrepreneurialism and tenacity of Claire and Emma Croft in pushing this through. And I have to agree with that. Having watched this from the sidelines, it's really taken a lot of grit and determination to get this through. And the Emma that we're discussing here is Superintendent Emma Croft, who's just been instrumental in this work as well.
Yeah, totally agree with that. Emma's been, a fantastic boss to work from. It's my boss as well. But it's been, there's been some days we've just had to keep going, but it's all for the better. It's for me. If that was my family member or myself, I would want the hub, and I would want that response rather than 2 police officers.
There's another question here again from Christine, and says, how many people staff the programme?
So in regards to the project, so there's myself and there's another chap who works 20% on it. And then there's a replacement for Emma. Now Emma's moved on to another job, so we have her, and that's it. I've got my training team because I work on different projects, but from Police Scotland, really the day in and day out business really is ourselves. Across in NHS 24, it's kind of like that as well. So there's the core people, so maybe about 3 or 4 of us who've been there all the way through, and then we pull in different people from different strengths when we need them for the evaluation and such, and training, and then the same for SAS. So really for us, it's been maybe 3-4 people across each organisation, and they have really never changed. They've been there from day one, and I think that's greatly helped, because as long as you've got the same people turning up because we meet fortnightly regardless, because we've always got something to chat about.
So on the actual phone calls that's coming through, so there's obviously the police control room, which is a huge staff group, and then ring fence across in the hub.
Over in the hub, so on average, and it would have been great for the hub to be here. I think they've got something like 70 psychological wellbeing practitioners, maybe, and again, I could be completely wrong with the numbers, but that's roughly how it is from the last time I've looked at something, and maybe about 30 nurses, 20, 30 nurses, and then they have seniors as well, but they're looking to grow because the volume is there, and we know it's going to get bigger. In fact, I was just writing some stuff about recruitment, the joint recruitment for nurses, for the project for advertising next week. So if anybody's in Scotland and works in that area, please consider it as a change.
I think just to clarify that with you, Christine, so there's the NHS, they're not all those 70 nurses are now working for Police Scotland. They're not all in the hub, but there'll be people ring fenced to work in the hubs. That's what you're saying, Claire,
yeah.
isn't it? Yeah.
So they always have one psychological wellbeing practitioner ring fenced for Police Scotland, the priority line to come in, but they'll also have a lot more obviously on shift, and sometimes our demand, and I've seen it, we have strangely we have really popular times, and it's not when you think it would be out of hours when core services are available. It'd be all Friday nights, it'd all be Saturdays. It's not. Tuesdays during the day, lunchtimes, a popular time for people to phone the police and we refer them in. Mondays is the slow day for everybody, it would appear to be. And between 6 and 7 in the morning is very quiet for referrals. But it's when the other services are open 24/7, we're putting people through. There is not an hour in the day that we haven't referred somebody.
Christine, you're just saying that you're trying to figure out how to build it. Where did you say you were, Christine? Was it in the Netherlands? No. Where did you say you were, Christine? I just can't see your name come. Oh, there it is. The US. Yeah, you need to speak to Amy Watson. I'm sure you know Amy already. But yeah, that. Is there any more questions here, or please raise your hand if you've got a question, if you'd like to ask live. That would be, can you just tell us a little bit more? Oh, here's another question. Do you think your new pathway has had better reach to remote and rural communities in ways that other traditional pathways never could? So just Scotland has got a lot of rural areas, and I know Claire touched on that earlier on. We've got a lot of islands. Claire tells funny stories about going off and training people in Benbecula, which is in the
middle of nowhere.
It's in the middle of nowhere. It's got nobody there except one police officer who's very happy. But I'll let you go on with that. So do you think that the new pathway has a better reach to the remote areas than that traditional pathway?
Yeah, I think a mix is really good. I think we need our local services for the bread and butter aspect, where they build up that relationship and they understand and such like. However, I think this is where it's worked, and I did a lot of work with our military defence police as well. So they're based. There's a lot of them based in Scotland, and they come back from being on submarines and such like, and they're using the pathway. They're not referring people in, but they're using it just through the public response. But yeah, certainly for me, and I found it particularly when, and as Inga said, I've had the pleasure of going around quite a lot of the islands in Scotland because of my work, and I've gone out and met a lot of people, a lot of police officers. Is a lot of the time
a lot of stuff on the islands where the whiskey's made, can I tell you, and the gin.
The gin, yeah. I'm always happy for a police travel, I have to say. But actually, I found it interesting what my own colleagues would tell me. So they won't really go to the GP for much because they feel it's a bit like everybody knows everybody. And if they reach out, if they buy an extra bottle of wine in the shops or extra toilet rolls, everybody knows it's everybody's business. And although the GP will obviously not disclose anything, for them, they won't reach out to maybe the more traditional routes for face-to-face support. But this is where it comes in handy that it's literally a phone call from your own house. So yes, and from our stats, because as I say, we're looking at everything, the demand is nationally across rural and central belt. our big cities, and particularly Glasgow, which has got more deprivation, has a higher number of calls than Edinburgh, for example. But what is interesting, an area in Scotland called Fife actually is second to the highest number of calls across Scotland, which has quite a good mix of rural and some larger towns, but no big cities like Edinburgh or Glasgow. But it's everywhere from, as Inga made mention, we have got people being referred, and it's immediate. So if you were on an island or you were in a very remote part of Scotland, you might have to wait till the weather gets good before you get off that island, because the ferries closed down or the little airport's shut. But we can get them access to that care straight away.
Okay. So it does shift. There's something there. I keep coming back to the word about dignity, but there's something there about privacy and it being a little bit more removed from somebody that you know. Yeah. Absolutely.
Yeah, and you know, and I go back to my work when I worked in public protection, and I used to say to people to reach out and maybe speak to, and at that point there wasn't really anything like this, because sometimes a stranger is a very good person to open up to, because you don't feel judged, you don't feel it can be so. Yeah, certainly our stats certainly prove that it doesn't matter where you are in Scotland, people are calling and we're referring people in, and the same for making the direct approach into NHS 24 as well.
Okay, thank you, Claire. I'm just looking, we've got, because we will be having a hard, finishing on time, so we've got 7 minutes left. Is anybody would like to put a hand up and ask a question? I can't see hands up, but it might be, oh, that's my own hand. There might be, Sarah, you might be telling me if I'm missing something. I can't see any hands up, but if anybody wants to ask a question, oh, you don't see any hands up. Thank you, Sarah. Can you just in closing, I'm just wondering, the nurses come in to work in the police control room with you.
Mm-hmm.
Do you see any professional, I mean, so obviously they have access to health files and the police files, that's right?
Yeah, so they're going to get access to our vulnerability database. So we hold all our detail, and they'll get access to our system for our incidents. So it's called Storm. So they'll get access to that. They'll also be they're going to be vetted up to a really good level. So they'll have their own police issue card. They'll be able to access, they won't be visitors. They'll actually be part of, they'll be on our systems and such like. And what we're going to do is we're going to start them just come in and just review an instance. It's really simple, because we found it's, start small and go smart, and then do bolt-ons, review it, see how it goes, and then look to do bolt-ons. We're quite keen to go down the route of professional to professional. So, we've got the tech now, because we're moving on, and officers are out there with their mobile devices, that we could look at doing professional to professional, so they can actually, when they're out there, they can speak back to the nurses and actually maybe see how the person's presenting more, so they do get that face-to-face assessment. Mm-hmm. So we're certainly looking at all little ideas for little bolt-ons to the nurses, but we'll land the really simple. The nurses just being in, they'll get instances that are referred across them for their assessment and such, and we'll see how it goes there, because one nurse, we've got funding for 6 nurses, so really one nurse per shift. I think they're going to be very busy, so we have to not swamp them.
No, I was going straight up my head. I was going to ask a really important question there. So that there's something there that's happened around the data sharing there, isn't there, in being able to make a collaborative assessment there. I'm just wondering if there's been different professional perspectives of need.
Well, they're going to get trained. They're going to go through a lot of nice, good learning with us. We're also going to upskill 2 police officers where they're going to be based, who are going to be their champion, who's going to support them, really embed them. But as such, as you know, they will be in the police, and the police will always take full control of that. They will have the full command of that incident at all times. And they're there as the professional advisor to give us that really good support. I know, I've done a lot, I've reached out to all our English and Welsh forces, and where they have them, they're at the stage now in some cases where they'll phone the person back and they'll speak to them. We're not at that stage yet. We're just going to land them at that nice level, see how it goes, because the last thing we'd want to do is tie them up on a phone call when they could actually provide support, maybe a more urgent and needing incident.
Mm-hmm. Okay. I'm just going to open this up to, is there anybody else got any questions or any comment that you'd like? Christine said here that it's a really valuable way to eliminate the stigma of going for mental health treatment. And it's really important in rural areas, as you state. So thank you, Christine, for that comment.
Yes, I know in Scotland, approximately maybe about 3 months ago, everybody in Scotland got a leaflet through the door about who to go to for what services. So, and it had about the hub, but people, I don't think, are reading things like that, or at the time it's not been relevant for them. Mm-hmm. But 3 months later, it maybe is relevant. So a lot of people phone the police because, they don't know who else to ask. And certainly when we've also had a lot of people who phoned up and they've explained what's going on in their life, and we've gone to refer them, and they're actually happy to do their own self-referral. So they'll say, no, it's fine, I'll phone them myself. I didn't know about that service, thank you. And we will let them just go and phone themselves instead of us referring them directly. So there's always a self-referral route as well for people who, and you tend to find that's people who didn't know who else to phone. They've never really been part of the system, and they were really in a situation where they really wanted to speak to somebody, but they didn't know who else to turn to, and they're actually apologising by phoning the police. They're saying, I'm really sorry. So previously we would have deployed to that. So and that's not a good thing, when you've got, I'm really sorry, I just want to speak to somebody about my anxiety and how I'm feeling today, and they're saying, but I don't know who else to phone, and they're apologising for phoning the police. So us being able to either, as I say, in some cases, we're happy to let people self-refer, or we will refer for them. It's quite simple.
I think we've got to the end of our time. I just want to, if you've got any questions, please just leave them. I'm sure Claire will get back to you. You can contact Claire directly. You can see her name in the, how do you find the current resource available for the MHH? Right, what, do you want to ask that, Victor? How do you find the current resource availability for the MHS, Mental Health Hub?
Maybe that's...
Yeah, there he is. Oh, we might have to go now. Here's me saying, put your hand up, Victor. And now I can't see you. Sarah, can you? Oh, there you are, Victor.
Yes, hello. Can you? I don't know if you can hear me, but sorry for jumping in at the last second. All right, wonderful. I was just wondering how you find the current resource availability, particularly for mental health nurses for the NHS 24, because I know that this is usually a big problem, because only about 1% of health practitioners are focused on mental health. And I was wondering how you managed to have such a great response time, considering how rare these workers usually are.
Can I just add one very quick thing? Sarah's just put a little note in the message to say that we don't have another session after this, so you can go a few minutes over.
All right, thanks. That's where it would have been great if my colleagues from NHS 24 had been able to come, because they're actually on the phone, they're doing their work just now. I can't actually tell you. I know certainly it's something that we worked on collaboratively, and we had our wish list that we didn't want our people being delayed in any way from our side. We wanted that response across there, and it was agreed. But yeah, that's probably something, apologies. I think NHS 24 would be best to go into more of the details of that, because it's more about their staffing and kind of their side.
So now I missed Victor's question, but if I've got right, are you asking about mental health, the availability of getting nurses to work in that system?
Yeah.
So in Scotland, we've got a chronic shortage of mental health nurses. And so I work and train in mental health nurses at the university. So we are working really hard to develop as many mental health nurses. Scottish Government's put a bit more money into developing that group. So there are people out there. The challenges, you know, for the work that Claire's saying, you have to be quite an autonomous practitioner. Even though you're really well trained up, you have to be really confident in your practice. So actually you need to have probably worked in a few different areas. So yeah, it's difficult. I having been a nurse myself, worked within the police, it's just the best job on earth. I just love it. I've never enjoyed such a job, apart from the one I've got now. But it's a great place to work. So it's quite an attractive place to work for nurses. And we have
them bringing in the role of the PWP, the psychological wellbeing practitioner, who's the first point of contact into the hub, where it's people who don't have the degree in mental health. However, they're not clinicians. However, they've got fantastic life skills. They're phenomenal communicators. They have worked on so many, outreach programs and all great walks of life, really lived experience for these people. So they're fantastic for, as you know, when it's a lot of people who just, they need to know how to ground, they ground them, they do the mindfulness, and then you have that clinician support continuously. So introducing, which is a really new thing as a psychological wellbeing practitioner, introducing that rather than always having the mental health nurse as the first point of contact. They're there to kind of take the initial call through, and then they can refer it. The nurse can quite quickly, or the senior can take over that call, or they give them direction, and they're there floor walking the calls. It's not that they're sitting in another office. They are literally on the floor with the psychological wellbeing practitioners.
And I'm just going to close it up in 2 seconds. But one of the other things, Victor, that's really interesting is that if we're stopping at that point, the very, very first place, and we're employing nurses at that very first point, we're not tying up nurses in the emergency department, which is a huge issue. It's a huge process, because that's where we should be treating time critical emergencies, not people who are necessarily distressed because they're lonely. And so I suppose we're shifting the resource, aren't we, from one area to another. I'm going to finish up because I know we have gone over. I just have to, we've already said this in the chat here, and I've said it at the very beginning, and I'm just in awe of Claire and her work. We all just look to her passion and her enthusiasm and drive, and tenacity is the word, because you need tenacity to get this off the ground. Oh my goodness. In a big organisation like Police Scotland and the NHS, which is like dinosaurs to move, it's a big, well, they're not dinosaurs, but big.
I equate it to a tanker.
Tanker's the word I'm thinking of. Tanker, not dinosaurs.
We don't want to be that tanker in the sewers just now, but no, I equate it. It is literally, we're like tanker, and we need to turn that, and we'll get there. Yeah.
So it's an absolute pleasure. Like I said, please ask Claire, send a message to her if you need to in the community chat. Thank you so much for attending the presentation. And yes,
I want to thank you to Inga for stepping in, and because I greatly appreciate it, because it would have been quite dry with just me going on about the pathway. So thank you so much, Inga.
Oh, you're welcome. And just before I leave, for those of you who were looking at working, I know Christine was saying, please get in contact with Amy Watson. Amy will be furious at me now, but I know Amy's been on this call in this session around CIT International, because their work is so amazing in the States and internationally around this area of work. So thank you all so much, and enjoy the rest of the conference.
Thank you. Bye-bye, everybody.